Okay, thanks very much. So we're starting early, so I get a bit of extra time. It seems only fair. Great pleasure to kick off this meeting, and as Neil said, many thanks to Ronan, who's worked tremendously hard in sorting this out, and obviously very generous industry support. My remit's to deal with TEM for early rectal cancer. Now, in contrast to most TEM talks, I'm not going to launch on saying how it is an alternative to radical surgery, but instead going to try to develop a bit of a theme that talks through how we can optimally manage patients who are on that TEM pathway. I won't talk to this audience a great deal about the technique. It's sort of summarised here. It gives a stable platform for operating within the rectum with really optimal views, allowing very precise full or partial thickness rectal excision. The kit's shown down there. This is a close-up of it. This is the old stuff. The new stuff doesn't look any more appealing. It looks like a sort of terrible accident in the Honda factory. And I like this photograph a lot because when you have a patient who wants a TEM and you really think they should have a radical operation, it's useful to show them exactly what you get up to when you do a TEM, and they all go towards radical surgery. Although I say it's been a stable platform, we've had some modifications of the technique. And this, once we get police clearance on this, we're going to hopefully publish it. This is an unstable platform for access to the rectum, but in fact gives tremendous views. I think I've lost my mic there. Now, the defining feature of early rectal cancer is the lack of lymph node involvement, really. It's usually early-stage disease, T1, T2, but it need not necessarily be. And we know from a number of histological factors that we can look at, we can gauge the risk of lymph node involvement. The size of the tumour, specifically looking to be under 3 centimetres, depth of tumour invasion, increasing nodal involvement with that, presence of lymphovascular invasion, the poorly differentiated tumour, all associated with increased nodal involvement. Now, we do our best to stage that preoperatively by MRI scan, endoscopic ultrasound and macrobiopsies, but it's really quite short of giving us a very accurate picture. Now, whenever we embark on a TEM talk, there's usually, within most audiences, a group of people who wince and feel uncomfortable because we've spent the last 100 years trying to improve our success for radical surgery, all the way from Miles to Moran. And Bill Heald has no small role in that with his evangelical approach to it. And really, Bill Heald could, or his practice could be credited with this dramatic improvement in local recurrence rates seen between the Swedish rectal cancer trial and the Dutch rectal cancer trial in the non-irradiated arms. So really, meticulous training, surgical technique has conquered that. And with that, many people say, well, look, we've just sorted out radical surgery for cancer. Why are we going to waste time with this distraction of local excision? And it really comes down to this balance between the big oncological heavyweight offering radical surgery, cure at all costs, but mortality from the procedure, morbidity from the procedure, versus this lightweight, this sort of soft fluffy who's interested in quality of life, avoiding a stoma and low morbidity. Now, through the last sort of decade, 15 years, there have been some fairly major publications that have put people off local excision. And this is one example from Memorial Sloan Kettering, looking at about 90 patients, and they identified the usual pattern of recurrent disease occurring in 20 to 40% of T1 to T2 tumours. Now, it's important to remember that that means 60 to 80% do not have recurrent disease. But the terrible message that came from the Memorial Sloan Kettering paper and many others was the devastating consequences of having local recurrence after local excision. These patients did badly. When local recurrence was picked up, they often had extra anatomical exenterations. There was a high rate of resection margin positivity, a high rate of subsequent failure, and poor overall survival. And that really set the scene that I think often diverted attention away from this really very simple fact that TEM cures early rectal cancer, and it's quite important to bear that in mind. It's good news for these little old ladies. And if we have a sensible approach to our TEM practice, early tumours, keeping the size less than 3 centimetres, making sure there's a complete excision, avoiding poor differentiation and avoiding these other poor histological features, then we can have a successful practice that translates through to local recurrence rates of less than 10%, which are not so different from that which we obtain at radical surgery. So when used sensibly, TEM seems to be a very reasonable approach to early rectal cancer. And I think we could say that it is the standard of care, in fact, for early rectal cancer, perhaps controversially. But as I say, part of the theme of this talk is really to look at what we do with TEM patients when things perhaps don't go quite so well, and what happens if we pick up unfavourable pathology on the TEM specimen. And I thought we'd demonstrate this with a couple of cases that are all linked. The first, an 85-year-old with a bit of comorbidity, but an anatomically perfect low mid-rectal, posterior mid-rectal tumour suitable for TEM, has a TEM, and the pathology shown here, T1, SM3, LY1. So not perfect pathology. Now, it depends who that person is, and if that person's a sort of robust ex-national leader, you can have a pretty difficult discussion with them, and you're going to explore, what options is she likely to have. So you'd sit down, just as Margaret Thatcher and Reagan sat down and talk turkey on it. And we'd have to say, well, your chances of recurrence probably fall somewhere between these T1 and T2 bars. So let's say around 20%. They're aware of the consequences of that sort of recurrence rate, i.e. dreadful, devastating consequences of recurrent disease, and then ask for what some of the alternatives are. We'll say, well, look, we can proceed to completion surgery, and we know that completion surgery after TEM is relatively safe, and the complications are much the same as a primary surgery. That is, a death rate of up to 13%, a 20% chance of major complications, and hidden in there is that misery of chronic pelvic sepsis from anastomotic leakage. If you don't have a stoma, you'll have poor function. If you do have a stoma, there's a very high chance it will never be closed. And there are sort of quality of life issues after this sort of completion surgery that probably mean you'll never quite be the same again. So the lady doesn't like that and wants to look at other alternatives. One thing we can reassure her of is that oncologically, when we take that subsequent complete resection, we'd expect her to be restored to the oncological levels that she would have had she had radical surgery in the first instance. And that's quite important to bear in mind. So the completion surgery does not compromise patients oncologically. But if we look at other alternatives in radiotherapy, there's remarkably little in the literature regarding radiotherapy in patients who've had TEM. These charts are thrown up from the UK TEM database, and they're tiny numbers, and in fact we can see from here that the survival in those who had radiotherapy for a high-risk TEM pathology was actually worse than those who were observed. Now that's because of bias, I'm sure, in the selection process. There are a few bits of anecdotal literature around. This paper looked at 20 patients who had T2 pathology after TEM. 12 of them had radiotherapy, none of them had local recurrence. 4 who persisted under observation did not have radiotherapy, 2 of them had recurrence, and that's the sort of level of evidence that's available for radiotherapy after TEM. It really is pretty poor. So in this lady, what we'd probably go for with that pathology is careful observation, and we haven't quite defined what careful observation is. Should we examine them in clinic once every 3 months? Should we do an MRI every 3 months or 6 months or 12 months, flex SIGs? But there probably is an approach within that should become systematic, that then allows us to identify recurrence at an early stage, and offer either surgery or radiotherapy. Now, let's say you've got the same pathology, but here in a thrusting world leader. Well, in this individual, if you were to have that sort of high-risk pathology, most of us would advocate radical surgery. Here we look at a chap, a flamboyant, sexually active European gentleman with the same pathology. Now, he's worried about his sexual function, and he wants to avoid radical surgery. The rest of the world thinks that it might be quite good to curtail his sexual function and advocates radical surgery with the hope of keeping him alive. All of this goes together to sort of bring together this sort of notion of trade-off when we're looking at the trade-off between oncological compromise and function, quality of life. And what's quite surprising in this practice is that people don't often behave as you would expect them to. And sometimes it's a middle-aged chap who's clearly a risk taker with his cigarette who'll say, look, I'm going to take the 15% chance that I'll get recurrent disease. And I think what's important for us to do is to try and create a safety net to help those patients. So when is this oncological trade-off acceptable? Well, we know that the recurrence rates of up to 40% with T2. Now, sadly, that translates through, in most of these studies into reduced survival. And that's a big problem when trying to sell this to patients. But I think there's been a bit of a con in all of this because most of the data over the last couple of decades has been generated from this forgotten tribe, a group of people who have comorbidity, elderly. They've had a bit of a one chance to have the cancer dealt with by local excision, and often those clinicians looking after them aren't particularly interested in picking up recurrent disease, so they're not pursued actively. And this inevitably has led to bias, I think, in most of these published series. And I think what's important to develop is TEM functioning as part of a very rigorous strategy to manage it. That will involve recourse to completion surgery if the pathology is unfavourable, identifying those patients who are at high risk, and for those who are keeping under observation, having a tight surveillance schedule such that instead of them coming with advanced disease, we're picking it up when it's still resectable and can be managed by anatomical resection. Now, there's a clue that that might just be possible in this paper from de Graaf in Rotterdam. This is a big centre for TEMS, and this paper doesn't give the whole answer, but it sort of is it's a bit of a tease as to how we might be able to perform. It's not randomised, but it looks at 76 patients who had T1 cancers dealt with by radical surgery alone under the Dutch TME trial, no radiotherapy. Compares them with a group of 86 T1s treated by TEM. In contrast to the forgotten tribe, these patients were followed up and managed under the standard Dutch colorectal cancer protocol, which is 3 to 6 monthly endoscopic assessment and ultrasound. Now, the groups were pretty evenly matched. The TEM group were a little bit older and their performance scores weren't quite so good. When we look at the TEM versus the TME surgery, it's as you'd expect. The TEM's a bit quicker, it's got reduced morbidity, and certainly no mortality. When we look, it's quite interesting when you look at the stoma rate in the Dutch TME group because it runs at 43% have a long-term stoma. That's something which we often don't think about, I think. As expected, well, if you do a local excision, there's a higher recurrence rate. That's exactly what we'd think. But then when we look at survival, and this is in contrast to most of the other studies reported on this, survival, looking at the two groups, is broadly equivalent at the time when this census was made. Now, these are all the patients who had recurrent disease or metastatic disease, and they fall into some quite straightforward groups. This is a lower group of patients who had metastatic disease after having radical surgery. They've got bad biology. They were going to die, whatever happened, and in fact, you could say they should have been better treated by chemotherapy first off. These are those who with metastatic disease who had TEM. You can say, well, they were lucky they didn't have radical surgery, but again, it's tumour biology that has directed the process there. And that leaves a little group who had TEM and experienced local recurrence. And the interesting thing here is that they're all still alive, apart from 2 who had non-cancer deaths. Now, what's particularly interesting is that in contrast to the Memorial Sloan Kettering data and lots of other data out there, these patients, when they had their surgery for recurrent disease, underwent anatomical resection, so standard TMEs, standard APR. Only 1 had exenerative surgery, and the R1 margin rate was very low. So these data on survival are very immature, but there is a clue here that if we are able to follow these patients up in a very close surveillance strategy, we can get the disease earlier, and that's quite encouraging for extending the role. So this is a sort of follow-up that's used in Holland, and they're now moving to use MRI as a routine as well. Certainly in our practice, we use MRI for all patients who are having TEM, whether it's benign or malignant, because 20% of the cancers are in fact are believed to be malignant preoperatively. And it means we've got a useful baseline specifically to look at the mesorectal nodes. Now, what can we do to extend this population who is going to be suitable for TEM? Well, three main areas. We can look at improving preoperative staging, all about defining this lack of lymph node involvement. We can look at the biological activity. We've already seen that some of these tumours are just behaving bad, and if we can pick that up, we can determine their treatment, and we can look at neoadjuvant or adjuvant therapies. Staging and selection. If we look at the literature on endoscopic staging of T-stage, it looks great, 90%, 85%. Likewise, MRI staging for nodal disease, 85%, 90%. But in routine practice, it's often really quite disappointing. And I think it's quite unusual for a clinical decision to be based entirely on the endoscopic ultrasound. Likewise with MR, it's fine at picking up positive nodes, but the absence of nodes on MR really is offering no guarantee to patients that their nodes are not involved. And in many ways, I wonder if we've reached a sort of limit of this anatomical staging, whether we're going to have to be looking at smarter ways of staging this. I think quite often what we see isn't quite what's there. And that's a big problem with these anatomical staging modalities. We could look at PET-CT, enhanced CT scan, either diffusion weighted or with nanoparticles. I don't think we're ever going to really use these to sort out preoperative staging when we're looking for microscopic disease. I think they will have a role in this very tight surveillance strategy that's going to pick disease up at an early stage. Now these, I'm positive they won't work, but we'll try to have a go. These are a couple of strategies for lymph node biopsy, sentinel node biopsy, that individuals are going to talk on in depth later. But it's incredibly tempting to think that we could use this sort of near-infrared technology to remove the primary tumour, then explore the mesorectum and pluck out the sentinel node. That could completely transform our approach to managing these patients. This is an alternative approach. Tarantino, and it is a bit Tarantino-ish, this. It's slightly scary approach where the posterior mesorectum is approached through the perineum with minimally invasive techniques, and an equivalent of an axillary node sampling or clearance is undertaken. This was published in 2008, and we've been looking for patients where we wanted to do this for that time, but haven't quite had the nerve to go with it. And I'm just not sure that this is actually ever going to go into popular use. Molecular profiling, well, there's tons of stuff on this. Phil Quirk's been involved in the talk, which I think is an abstract form only in ASCO, looking at sort of RNA profiling of tumours. It was of great use in working out those node-negative quasar patients who were less likely to respond to chemotherapy. Simon Back, who's here, has published recently on methylation profiling of rectal cancer. Now, if you look at the literature, there's actually been a lot of this stuff floating around for a decade or so. There's great promise that it's going to start personalising surgery and treatment, but I think we're a way off. When we look at neoadjuvant treatment, it really is quite enticing, and Les Oettch has been at the forefront of this with the most remarkable results. This paper is looking at very finely staged T2, T3 cancers with no nodal involvement who undergo chemoradiation and then TEM excision. The failure rate is 5%, which is absolutely stunningly good, and this is on a fairly significant number of patients. He's recently published, and I think it's just available as an EPUB, their follow-up of T1 and T2 tumours. Now, the T1 tumours were managed just with TEM. The T2 had chemoradiation followed up by TEM. Good number of patients, 135. Very intensive multimodal preoperative staging. And they always go for whichever staging modality upstages a tumour. 51 T1s, 84 T2s. Final pathology showed complete response in 17%. Local recurrence rate, 4.7%. I mean, absolutely phenomenally good numbers. There's lots out there on neoadjuvant chemotherapy followed by TEM, but the numbers are never quite good as this. The outcomes are never quite good as this. And you've got to wonder why it is. They certainly have been vigorous in their preoperative assessment. with imaging, and also with macrobiopsies. And this is an approach that Gerhard Buss also recommended, taking big chunks of this tumour. And if you find that the tumour is undifferentiated or it's got lymphovascular invasion, you may exclude that tumour at a very, very early stage, thereby enriching the population who are likely to benefit or likely to have good results. The other approach that they have is that they do preoperative circumferential biopsy and tattooing. And that means that post-chemoradiation, there's no search for a scar. You can see exactly the area with a 1 centimetre margin that needs to be excised. They also undertake a most radical TEM, I mean quite a terrifying TEM, where the block of mesorectum, much like the Tarantino type block, is removed with the full thickness excision. So it's quite a different TEM operation from most of us are doing, and it's hard to know which part of these components, and maybe it's all of them, that translates through to those great results. Now, there's no doubt that the neoadjuvant treatment is going to be a major question to be answered over the next 10 years. Simon Bach is the PI for the TREC trial, which is just about to launch in its phase 2 pilot study, really looking to see, much in the way that was done for the prostate cancer, can we take a patient and say, look, you've got early stage disease, how about being randomized to short course radiotherapy and then TEM versus radical surgery? That's quite a big difference. And we'll have to see if it can be sold to patients. And there's a great deal of effort going into the marketing behind that. And I suspect it will be successful. So to conclude on this, I think we've already seen that TEM's established in its management of early rectal cancer, certainly in the comorbid population and increasingly within the general population. I think we can extend that role by multiple approaches, and in fact it's going to be a multimodal approach that really increases the population to whom TEM can be applied. Better staging, maybe molecular profiling, better use of adjuvant treatments, neoadjuvant treatments. As we mentioned, there's nothing out there about just giving people radiotherapy after an unfavourable TEM. Very, very little. I think what's going to be key is meticulous post-TEM surveillance, and what's going to be even more important in this big balance, because I think it's going to be quite a risky time for TEM surgery, and there's going to be some patients who will do badly for it. We're going to have to keep very, very good audit of these, either within good clinical trials or within national databases such as the UK TEM database, with a move not just towards whether or not they die or whether or not they have recurrence, but whether or not they have a quality of life that makes it worth the risk and survival. And I'll end there.